Medurstand. Understanding medicine.
Professor Aziz-ur-Rehman again, and after a detailed discussion on normal X-ray chest, we are going to take up various abnormalities, and today we're going to talk about pleural effusion. Pleural effusion is a fairly common condition, and in the examination you will be expected to diagnose pleural effusion, and then based on the pattern you will be asked about the etiology. It is possible actually to determine at least fairly accurately the etiology of pleural effusion on X-ray chest. And there are actually various radiological appearances. So I will show you the most common one and then the various other abnormalities so that you are able to pick up the abnormality, whatever the pattern it might show. So today's presentation is purely focused on pleural effusion, and we will of course be talking about the radiological appearances. We will not go into the details of etiology and the treatment and other things. Those of you who have seen my earlier video, the normal X-ray, they would, I think, immediately appreciate, and of course others who already know the X-rays, they would also immediately appreciate. After making sure that this is normally rotated person, and then this is the right side, and this is the tracheal shadow, you come immediately to the abnormality. I told you that after just making sure that everything is okay, then you come to the abnormality. So in this X-ray, I think there is very obvious abnormalities here. Now, what is the abnormality? You see an opacity. In X-ray, I think you should always describe an opacity first and only then draw a radiological conclusion, meaning that this opacity is most consistent with, in this case, pleural effusion. And then you draw further clinical inferences, like for example, this is unilateral large effusion. It would not be consistent with heart failure. So I think that is how we go. So let's come to this opacity. There is an opacity on the right side of the lung in the lower part, and this opacity is homogeneous or uniform. You see, in this opacity, you don't see any lung shadowing. This is called homogeneous opacity, and it is uniform, and you don't see any lung markings, and it is also fairly dense. It is as dense as heart. So you can imagine something like fluid filling the whole chest. Then you can comment on these angles. You do not see right costophrenic angle because this is all filled with fluid. And you also do not see right cardiophrenic angle. So right costophrenic angle is obliterated and right cardiophrenic angle is obliterated, and you don't see the diaphragm because this opacity is in contact with the diaphragm, so you don't see the demarcation. This part must be liver and this part is opacity, so you don't see the diaphragm, and you also don't see the right cardiac border because again it is obliterated. But most important thing, which is the characteristic of pleural effusion, is the upper border. You see, the upper border of the pleural effusion is always like this, curvy linear. This is the most dependent part. On both sides, it rises up. More prominently on the lateral side. You can see this goes up like this. In this case, it goes, I think, quite up. But normally it goes up to this. So you see the curvy linear upper border. This is also called meniscus sign. And I think after you have picked up all these abnormalities, I think it is fairly obvious that this is pleural effusion. Then you must also comment on the position of the midline structure. A large pleural effusion may push the midline structure to the opposite side. In this case, it does appear that the trachea, this aorta and the heart is somewhat pushed to the left side. Not grossly so, but it does appear to be shifted to the left. Not trachea, because trachea in the upper part. Any opacity in the lower part is likely to push heart, and any similar thing which takes volume in the upper part is likely to push the trachea. In this case, this large opacity is, I think, pushing hard to the left. So if I have to describe it again, there is a large opacity on the right side of the lung in the lower part, which is homogeneous, uniform, with no lung markings, and there is no, the right costo-phrenic angle is not obvious, diaphragm is not visible, right cardiophrenic angle is not visible, right cardiac border is not visible, and there is classical curvilinear shadow, and there is slight shift of midline structure to the opposite side. These features are suggestive of moderately large pleural effusion. So this is how I will describe it. Now, what is the cause of this pleural effusion? Perhaps some inflammatory or malignant condition, because those conditions which there are transudate like cardiac failure, nephrotic syndrome, cirrhosis, you normally see bilateral pleural effusion. In that case, you may also see small right-sided pleural effusion, but if it is large, then it is perhaps some inflammatory condition or maybe malignant condition. So this is, I think, the commonest appearance of pleural effusion on X-ray. Now this is again pleural effusion, but you see two things. Let me see if you can pick up. I'll give you a few seconds. See if you can. Of course, this is opacity, very similar to the one we saw earlier. Uniform, homogeneous, no lung markings, no costophrenic angle, no diaphragm, no cardiophrenic angle, no right cardiac border. But in this case, there are two differences. One, see the upper border. In this case, the upper border is absolutely sharp, right? So whenever you see a sharp border like this one, with an opacity like this, this suggests that there is perhaps free air in the lungs. And you can actually see free air here. Please appreciate this very, very thin line indicated by the arrow. So this is actually air. Perhaps this is a fact of some trauma. A traumatic pleural effusion may cause effusion as well as air. This would be described as hydro-pneumothorax. Hydro referring to the fluid and pneumo referring to this air. So this would be described as hydro-pneumothorax. This may be a traumatic pleural effusion, or it may be actually a complication of a procedure called paracentesis. Maybe somebody tried to remove some fluid on the right side for the diagnosis purposes, but accidentally some air entered. So this is called hydro-pneumothorax. This is different than the typical pleural effusion because it has got very, very straight border, and plus you can see the air here. Now let's see another film. What do you see here? Again, I think the same, exactly similar picture. Dense, uniform, homogeneous opacity on the right side. You don't see right costophrenic angle, right diaphragm, right cardiophrenic angle, right cardiac border in this part. This one is slightly smaller than the one we saw previously, but this is, and in the upper border is classical curvilinear. But something, if you have appreciated, right border is not actually in its normal position. It is somewhat pulled toward the pleural effusion. A normal pleural effusion should not pull the structure to its side. It should actually push it to the opposite side. But you don't know what is underneath. There may be, what we see is pleural effusion, but there may be some additional pathology underneath like collapse. And if you see the episode, in this X-ray, if you see this one, this is the normal, and there appears to be some fibrotic changes. So if you correlate these fibrotic changes with pleural effusion, this might suggest the possibility of tuberculosis. Tuberculosis is the commonest cause of unilateral pleural effusion in our part of the world. So anybody showing large unilateral pleural effusion, the chances are that this is tuberculosis. But of course, the diagnosis will become further likely if you see additional pathology like this one. So this is again a right-sided pleural effusion, moderate size. Okay. Now this is again a fusion, but this time it is on the left side. You see, this is a large opacity. This is the biggest of all three we saw. This is the large pleural effusion. You don't see left costophrenic angle, right, left cardiophrenic angle, diaphragm, and there's a uniform opacity, no, and extending from the heart to the chest wall, as if there is something which is free, which occupies the whole hemithorax, and then you see the curvilinear border. Okay, so this is pleural effusion. Now please note down one thing. If you trace the trachea, the upper part of the trachea, this one trachea is normal, but you can see the carina is somewhat pushed to the right side, and the right bronchus and left bronchus. I'm not sure if you can appreciate this, but it is quite obvious to me on this computer screen that this is shift of lower part of the tracheal structure onto the opposite side. And if you see right cardiac border, this is also displaced to the right. So this big pleural effusion has pushed heart and the lower part of the airways to the right side, further confirming that this is something which takes up the space. Now, just I think one discussion which is relevant here, these type of opacities are caused by three pathologies. One, pleural effusion. Two, pneumonia. Three, atelectasis. Primary atelectasis, when there is blockade of a bronchus and the lung collapses. There is a secondary type of atelectasis also when it occurs into after pneumothorax. No, we are not going to discuss that at the moment, but the primary atelectasis. Okay, so how to differentiate? They all cause similar uniform density opacity, but in pleural effusion, since there is increased volume, something takes up space, it is likely to push the midline structure to the opposite side. If this is a fusion, midline structure would be pushed to the opposite side. Now, if this was collapse, there is a loss of volume, lung shrinks, and it will actually pull the midline structure toward the opacity. And in pneumonia, in most cases, in pneumonia, alveolar air is replaced by exudate. So in pneumonia, there should be no significant shift of midline structure. Although in pneumonia, there could be actually underlying collapse sometime, and in pneumonia, there may be some increase in volume, but mostly in pneumonia, there would be no significant shift of midline structure. Of course, you know, there's a condition called parapneumonic effusion. If somebody has pneumonia and then develop pleural effusion, then the feature of pleural effusion will be added. So you can see both these x-rays, and I think very sure these are two different persons. This is pleural effusion, this one is also pleural effusion, both left side, and female x-ray. You can't of course tell, but this is most probably either tuberculosis or maybe malignant. And one-sided malignant effusion, you should always examine the breast, because it could be actually local infiltration. So this is another x-ray. Let's see some more. What do you see? Do you see any pleural effusion here? This may be slightly tricky. If you see the right side, nice clear right costophrenic angle, nicely outlined diaphragm, nice clear right cardiophrenic angle, and no opacity here. But if you see the left side, it appears the same normal. But then if you see, what is this thing? If this is gastric bubble, the gastric bubble should be just immediately before the below the diaphragm. If that is the case, then this shadow is perhaps not the diaphragm. Diaphragm is perhaps somewhere here. If that is true, then this must be something above diaphragm. Yes, this something is called subpulmonic pleural effusion. Sometimes the fluid, if it is small in quantity, it just accumulates below the lung and above the diaphragm, and it may not make that classical curvilinear upper border. It may still maintain its normal rounded convex upward shadowing, but this gastric bubble and the location of this shadow, this is higher than this one, that tells you that this is perhaps effusion under the diaphragm. This is called subpulmonic effusion. The etiology is the same as that of other effusions, but the radiological appearance is different. So this may be slightly difficult to pick up. Now, of course, you have to correlate with clinical findings. Now, if there is still a doubt, you could actually do what is called lateral decubitus X-ray. Now, patient will be asked to lie on the left side, and this fluid will redistribute and will make a shadow like this one. If this is fluid, it will redistribute and make a linear shadow along this chest wall if patient lies on the left side. Or ultrasound can actually tell you if this is pleural effusion. Subpulmonic pleural effusion. So I'm going to show you some other variants of pleural effusion to complete the module. Now, this rounded opacity, if you have to describe this opacity, it will be described as fairly large opacity, which is oval shaped, and you can describe in centimeters. This one is like maybe 8 centimeter. This may be 10 or 10 centimeters. This is just my guess, but you could actually measure it. And there is no caliper given. Sometimes there is a caliper given, but no caliper. But you can compare it with the heart. So it's just smaller than heart, but fairly big. Normally, one would consider a tumor or an abscess, but this could very well be an effusion. Sometimes effusion may be encysted in oblique fissure or transverse fissure or against the chest wall. Now, this one, for example, is actually encysted effusion in the transverse fissure. This is the transverse fissure, and this may be an encysted effusion. This diagnosis may not be easy and can always be challenged, but sometimes if you do an X-ray and then you do an ultrasound or you do a lateral decubitus, that will confirm the diagnosis. You have to obviously correlate with the clinical condition. These two may be encysted effusion, this one in oblique fissure, this one in the transverse fissure. And I'll show you some more images of encysted effusions. They will make the concept better. This one, for example, this one is clearly pleural effusion, but this is encysted against the chest wall. This side is clear, but there is an effusion, this is the pleural border, and this effusion is encysted against the chest wall. Most probably, this is an inflammatory condition of pleura, maybe tuberculosis, maybe empyema. This type of pleural effusion may be difficult to diagnose, but those who are experienced, they should have no problem. In this case, the lateral film will be actually really helpful, especially if you want to do paracentesis, if you want to remove fluid. I think you need to either do a lateral film to exactly localize where in the chest wall is it loculated, is it in the posterior part or the anterior part. The lateral film tell, or you may do an ultrasound. But on PA film, it would look the same. Encysted pleural effusion, most probably due to some pleural inflammation. Now, what is this? Do you think this is pleural effusion? And normally, pleural effusion cause a shadow which has got a curvy linear upper border. But this one is a shadow which is occupying the whole right hemithorax. And you don't see diaphragm, you don't see costophrenic angles, but the opacity is not that dense. And this is perhaps somebody who has pleural effusion, but this is an film taken when patient was supine, as you can see here, supine. Supine is patient lying on the bed. So when patient is lying on the bed, the fluid will redistribute along the entire posterior chest wall, and the appearance would be like this. A uniform but less dense opacity spread across the whole right hemithorax. It is unlikely to be collapsed, because the midline structures are still in the midline, it is unlikely to be a big tumor because the midline structures are not pushed to the opposite side. It is perhaps pleural effusion, but it is not massive. It is occupying the whole right hemithorax because patient is supine. So this is another look of pleural effusion. Now this is what I described as lateral decubitus. If patient is asked to lie on the left side, and a patient is lying on the left side here, and this is the fluid. You see, this whole thing is fluid. Because fluid is movable and it takes the most dependent part. When somebody is lying on the left lateral side, then this would be the most dependent part, and this is shown like this. Lateral decubitus view. Now this is another encysted effusion. You can see this one. This is not very clear, but if you see this one, and this one, I think if you trace transverse fissure here, this is the encysted effusion in the transverse fissure. And this is another encysted effusion in the lower part of the transverse fissure. These two would look like opacity. In this case, this encysted effusion is this rounded opacity. And if you don't see this film, you might actually think that this is a tumor or an abscess. But if you compare this X-ray with the lateral film, it is more obvious. This spindle shape tapering on both sides. This spindle shape opacity is typical of encysted effusion in the oblique fissure. This one again, you can see this pleura, two layers separating from each other, and this is fluid, but here it is just an opacity. And you can see these are perhaps X-ray electrodes, and you can see these metal clips. Most probably this patient had undergone some major procedure like cardiac bypass surgery or something, thoracotomy at least. So this is another type of encysted pleural effusion. This may be actually due to heart failure because of the cardiomegaly also. Now this is another effusion, and this is not lateral decubitus. This is erect film. Patient is standing, but you can see that this effusion has this is called lamellar. This is lamella. This effusion which rises like this in a band-shaped pattern against the chest wall, not occupying the most dependent part. This is called lamellar pleural effusion. The etiology, the differential diagnosis, and the treatment plan will be the same, but you need to familiarize yourself with this look of pleural effusion also. Lamellar pleural effusion. Now this, I think X-ray shows you why I told you that pleural effusion is best appreciated, a small pleural effusion is best appreciated on the lateral film. Now if you see this X-ray, the lateral film, lateral film, you can see this opacity here, but there is no such opacity on these angles. Now this picture shows you the most dependent part is this posterior recess. So that is why a very small pleural effusion may be seen on the lateral film, not on the PF film. But normally we do PF film only if we had suspected pleural effusion and PF film has not shown it. Maybe you can do the lateral film also. What do you see here? This is, what do you think? I think if you can figure out, this is bilateral pleural effusion. You see, this border, it goes up. Right costophrenic angle is obliterated, and the lateral part of the diaphragm is also not clearly visible. But it's small effusion, so small right-sided pleural effusion. Similarly, you have obliteration of costophrenic angle on this side also. So it is bilateral pleural effusion. Now if you notice, this patient also has somewhat cardiomegaly. This we are going to discuss in another module. but there is cardiomegaly and there is bilateral pleural effusion, and you can see these metallic stitches also. So most probably this patient has got heart problem, and this may be cardiac failure. So cardiac failure is one of the causes of bilateral pleural effusion. This one is the same, but slightly more pronounced. You can see in this case there is again bilateral pleural effusion, but compared to the previous X-ray, the pleural effusions are bigger. In this case, the costophrenic angles are obliterated and cardiophrenic angles are also obliterated. So there are bilateral curvilinear upper borders, the so-called meniscus sign. So you can't really appreciate the heart size. So it is not possible to tell if there is cardiomegaly or not. But there are other causes of bilateral pleural effusion. This patient, most probably a woman, must have another cause. So this is definitely a case of bilateral pleural effusion. So we have seen various different types of pleural effusions. Now, just to sum up the radiological signs, homogeneous dense opacity in the dependent part of one or both lungs with classical upper border. So that is the main description. Obliteration of costophrenic and cardiophrenic angles, and lack of demarcation of diaphragm and cardiac border. Push of midline structure to the opposite side, and various types as classical with curvilinear upper border called meniscus sign, or with flat upper level when there is air, hydro-pneumothorax, or encysted effusion, which are also called vanishing tumor, because with time they may disappear, and tumor of course never disappears. But if there is a tumor-like opacity and later it disappears, it is also called phantom tumor. Phantom is something which is not real, or sometimes it is called vanishing tumor because with time it disappears. And then subpulmonic effusion and lamellar effusion. There may be bilateral effusions. So at that, I think completes our module on pleural effusion. This cartoon will give you a very good idea about various types of pleural effusions. This one is classical, taking up the lower part and then obliterating costophrenic angle, cardiophrenic angle, uniform opacity, and curvilinear border. This may be subpulmonic. It appears as if the diaphragm is elevated, otherwise there is no meniscus sign, but this could be difficult to pick up. And if it is on the left side, I think the stomach bubble will help you. Otherwise, you could always confirm it with ultrasound. Then this is encysted effusion. It could be anywhere, and in this case, it is encysted in the transverse fissure. Then we could have lamellar effusion, which rises along the pleura. It may show on the bottom also, but sometimes the only thing you see is this lateral column, as if there is pleural thickening. So this is another type of pleural effusion. Similarly, you could also have this type of pleural effusion in the mediastinum. Now this might look just like a mediastinal widening, but of course high index of suspicion will lead you to the right diagnosis. We have discussed the common features of pleural effusion. I think it would be right to just give you a brief outline of the causes. You could have unilateral pleural effusion and you may have bilateral pleural effusion. So let me just very briefly give you a short list of common causes. Of course, you will find a much longer list in the book, but I'm going to give you the common conditions. So in unilateral pleural effusion, in our country, the commonest cause of unilateral pleural effusion is tuberculosis. This patient may not have other features of tuberculosis. Lung fields may be otherwise normal, but there is just a pleural involvement, and if you tap this fluid, you will find an exudate, and you may find also AFB and TB DNA. So this is, I think, the common cause. Then malignancy is another common cause. Carcinoma bronchus or breast cancer can cause malignant pleural effusion, occasionally the malignancy of pleura itself. Then pneumonia may be complicated by what is called parapneumonic effusion, so that is another cause. Then pleuritis. Sometimes patient may have pleuritic pain and you may auscultate, and when you auscultate you may find a pleural rub and there may be small pleural effusion. This used to be called pleurisy, but these days we call it pleuritis. This is a viral infection. So these are causes of unilateral pleural effusion. In bilateral pleural effusion, I think I would put cardiac failure at the top because that is a condition you don't want to miss. Congestive cardiac failure, there would be bilateral pleural effusion. It usually starts from the right side, so there may be actually a case where there is only right-sided pleural effusion, but when it increases inside, then there is usually bilateral. There would be additional features which we will discuss in the cardiology module. Nephrotic syndrome, cirrhosis, and hyperproteinemic state. All these conditions, because of reduced osmotic pressure, fluid tends to leak out of the blood vessels, so it tends to accumulate in all serosal spaces like pleura and abdomen. So I think that is another cause of bilateral pleural effusion. Connective tissue disease, again, like SLE, systemic lupus erythematosus, can cause unilateral or bilateral pleural effusion. I hope this was of some help, and I'm Professor Aziz-ur-Rehman from Medurstand. Please join me in my subsequent videos. I'm going to cover all common pathologies seen on X-ray, pneumonias, cavities, abscesses, atelectasis, and all the stuff which you will encounter as an internist. Thank you very much. Looking forward to see you again. Professor Aziz-ur-Rehman from Medurstand.